Now, I would like to present our first speaker, Dr. James Mastrianni. Dr. Mastrianni is a professor of neurology and director of the University of Chicago Center of Comprehensive Care and Research on Memory Disorder, also known as the Memory Center. He received his medical training at McGill University in Montreal, completed his residency in neurology at the University of Pennsylvania, and a research fellowship at the University of California, San Francisco, before moving to the University of Chicago to develop his research program and clinical and research program. He diagnoses and treats patients with dementia, and his laboratory studies the molecular basis and treatment of neurodegenerative diseases. He is the author of numerous scientific publications, book chapters, and review articles in the field of neurodegenerative dementia, and he is the recipient of many awards and honors. Today, he will provide an overview of FTD, ALS, and dementia observed in ALS patients. Thank you, Dr. Mastrianni.
Okay, thank you very much, Jumana. I'm going to share my screen and get started. Okay, so let me minimize so I can see. Okay. All right. So again, thank you for the invitation today. So as Jumana mentioned, I do see patients primarily with dementia. I am not an ALS specialist, but we see a lot of patients with overlapping syndromes. And the more and more we look at patients with dementia these days, the more we realize that it's not so straightforward that people fall into a specific category of dementia, that there's a lot of overlapping features in various dementias. So even in Alzheimer's disease, we may see movement disorders or problems with people having some physical difficulties associated with the dementia, visual difficulties. And in this case today, what I'm going to talk about is how patients with ALS can also develop a dementia syndrome, and it's primarily called frontotemporal dementia. And so I'm going to focus first on just talking about dementia in general, just so you have a good idea of what it takes to make a diagnosis. And so when you think about this disorder, this combined disorder of frontotemporal dementia and ALS, think about a patient who has maybe one or the other symptoms that we're going to describe, and then develop a syndrome that includes both of those features of those two diseases. So just looking at dementia we now call major neurocognitive disorder. It's a better term than dementia. Dementia implies kind of a craziness, so we're really trying to get away from that label. But I may still pepper my talk today with the word dementia since it's so ingrained. But think of it in terms of a disorder of cognition. And characteristics of dementia are that it's a progressive decline in cognitive abilities that lead to a functional dependence. And so what does that mean? That means that the cognitive dysfunction produces an impact on patients, so they're no longer able to do things on their own and get work done that they need to get done, and they need a little help from either caregivers or family members. Now, the cognitive domains, when we think about dementia, of course, most people think about Alzheimer's as the primary dementia, and it is the most common of the dementias. And the major feature that people note or equate with Alzheimer's disease is a memory problem. But there's really more to cognitive function than just memory. So learning and memory are some of the main features that we associate, but also language function, putting together words, our word knowledge, being able to speak in a grammatically correct way. Perceptual motor skills, so eye-hand coordination, carrying out a complex movement with your hand, those are actually cognitive skills. Now, the ones that I have highlighted, especially in yellow, are things that happen with frontal lobe disorders, complex attention problems. So being able to sort of, we talk about multitasking, but people don't generally multitask, but they can keep many things in their head, and we can all look at a situation and maybe put it together and sort of keep it organized in our head. But that's a little difficult for people with a disorder that affects the frontal lobes. Executive function is how we sort of organize our day and plan things sequentially, going 1, 2, 3 rather than 1, 3, 2. And I'll talk about that. And then social cognition. And this is one that most people don't even think about as far as the dementia goes, but being able to understand what's appropriate, how to interact with people in an appropriate way. So our comportment, we understand what's right and wrong and normal behavior in certain situations. And in patients with frontal lobe disorders, that is a major problem. So as I mentioned, in order to make a diagnosis for us, that these cognitive problems have to be significant enough that they interfere with your usual routine at work or play. So they can affect your recreational activities, or they can affect your job if you're still working. And typically we think of these as irreversible conditions when we're talking about a neurodegenerative disease. And so the disease is progressively killing our brain cells, essentially. And it's, at this point anyway, irreversible, that there's no good treatments for these diseases. But there are some, when we evaluate patients, that are reversible conditions that could be affecting patients. So organ function, liver function, kidney function, infections, and things like that, that we have to rule out. One of the most common questions that I get from patients is, what's the difference between dementia and Alzheimer's disease? And so this slide is really to help us understand the term dementia. Dementia is a clinical syndrome. So again, it's cognitive problems that interfere with your work or play. But it's the result of an underlying disease process within the brain. So this underlying disease is what's producing the clinical syndrome. And Alzheimer's is the most common of all the dementias, but there are several other causes of dementia. And we're going to talk about frontotemporal dementia today. And again, so these dementias, especially these neurodegenerative type dementias, result from the premature death of our brain cells or neurons. So the syndrome that we see, the dementia syndrome that occurs in patients, depends on where the disease is affecting the brain. And so here's a picture of a human brain for you, outlining 3 major regions of the brain. This is the frontal lobe. So you can see it's a pretty large area of the brain, and this is where your forehead would be. And so behind your forehead, and your eyeballs maybe would be right here. And this is the temporal lobe of the brain, and then this is the parietal lobe. So I'm going to just focus on those 3 lobes because they're important in dementias. If we look at Alzheimer's disease, Alzheimer's affects primarily the temporal lobes and the parietal lobes. And the function in the temporal lobe is primarily memory. So the hippocampus is an area within the temporal lobes that allow us to consolidate memory, learn new things, put new information into our brain so that we can later go back and retrieve it when we desire. Language is also a function of the temporal lobe. In some other areas, it also is involved, also in the frontal lobes a bit. But language, and especially your word knowledge, so understanding or your vocabulary and your lexicon is located there, and your semantic knowledge. So all the things that you've learned in the past kind of are consolidated here. The parietal lobe carries on some functions like mapping, visual spatial function. And this is how you get in the car, you're going to plan a trip to Target or a Jewel, and you're envisioning the route in your mind, and you're using your parietal lobe to kind of map out that strategy of the streets that you're going to take. It also helps us to carry out some learned motor movements. So being able to use your hand and appropriately stick the key in the lock and turn it appropriately, and some other activities. And also, interestingly, in the parietal lobe is your calculating abilities. So how you can manipulate numbers in your head and do some simple calculations. So there's a variety of other functions. But those are what are primarily affected in Alzheimer's. So we look at the memory function. Alzheimer's starts here and then works its way back to the parietal lobe. Now, in other diseases, like frontotemporal dementia, they affect primarily the frontal lobe. So the main feature that's carried out here is behavior. Again, this is our area of our brain that tells us what's right and wrong, how we should be behaving in a certain situation. Our social cognition, reasoning, judgment, executive function, and flexibility. And so I'm going to talk about those things as we talk about this disease. So let's jump ahead a little bit. Why would we be connecting ALS, a motor neuron disease, a disease that affects the nerves going to our muscles from our spinal cord? Why would we connect that to a dementia? Well, it turns out that, in fact, your motor neurons that come out of your spinal cord to feed your muscles are also linked to neurons or brain cells in the brain. And so the primary area that Alzheimer's or that ALS is generated from, essentially, or a motor movement is generated from the cortex in our brains. And that leads to the output either in the brainstem to your facial muscles and your tongue and swallowing muscles, or out to the spinal cord to feed your arms and legs. So there are motor neurons that are located in the brain that really are the seat of your motor control. And if you look at this from the side view, you can see that the motor cortex, there's a strip of brain cortex where these neurons originate, and these sit in the frontal lobe. And so you can imagine then that disease affecting this part of the brain may spread to the frontal lobe and cause symptoms. And it's kind of interesting that if you look back when ALS was first described, there was a description of cognitive dysfunction in patients with ALS, but it was pretty much ignored because the main feature of the disease was the progressive muscle weakness that people had. And then even autopsy studies that looked at these cases early on, patients with ALS, did see more areas of the brain than just the motor cortex involved, so spreading into the frontal lobe. So it's always been there, but really in the last several years, now focused that there is a link of ALS to dementia. So in 1993, there was a study in which they looked at 71 patients and recorded presenile dementia. So they actually were screened for dementia, and those patients met criteria for dementia. Presenile means under 65. So this is a little atypical for Alzheimer's. We do see young onset Alzheimer's disease, but these were presenile dementia. Again, not the common form of Alzheimer's, but they also had motor neuron disease. So that kind of, and then if they looked at the pathology in these cases, and they found that the pathology in the brain differed from the typical pathology that we see with Alzheimer's disease, and the disease primarily affected the frontal lobe. And this was reminiscent of a disease that had been described, known as frontotemporal dementia. So this kind of set things off. And then it wasn't until 2003 that Catherine Lomenhirth at UCSF, actually a former resident of mine when I was at UCSF, found that in fact there were 15% of the patients that develop FTD develop motor neuron disease. So this was really showing that if you look, you will likely see an overlap of these two conditions. In 2006, there was an autopsy series that found accumulation of this protein called TDP43 in the neurons of the majority of patients with either ALS or FTD. And that was really the remarkable study that showed that these two diseases really overlap significantly because the pathology that they had was in common. And it's now recognized that TDP43 is the most common pathological finding in both ALS and frontotemporal dementia. So there's an overlap of the region of the brain involved and the pathology associated with it. So what is ALS/FTD or FTD-ALS? It's really a spectrum disease that we see that includes features of both FTD and ALS. And so you can imagine on two ends of the spectrum that there may be pure cases of frontotemporal dementia or pure cases of ALS with a broad range of increasing symptoms of FTD in these patients and increasing symptoms of ALS in those patients. And this corresponds to what's seen with the pathology in patients, that the more FTD is seen with ALS, the more frontal the pathology of this TDP43 is seen. And again, with FTD, the more that the pathology is seen, FTD, ALS, that in pure FTD, the pathology may be very frontal, and FTD, ALS, it spreads more towards the motor cortex and also in neurons, even within the spinal cord. And this also corresponds to functional brain imaging. When people look at the range of disease in ALS, functional brain imaging looks at activity of the brain, and you can see decreased activity in and around closer to the motor cortex. And the more and more it spreads to the frontal cortex, the front part of the brain, and causes this FTD syndrome, the more the decreased activity correlates to the front part of the brain. So we can see it in life in patients too. So let's talk about some general aspects of the frontotemporal dementia, or FTD. Again, this is a progressive neurodegenerative disease that mainly affects the frontal and temporal lobes of the brain, that leads to primarily behavioral changes and other cognitive decline. It can affect as many as 15, the numbers are quite varied depending on who does the study, but maybe about 15 people per 100,000 within the age group of 45 to 64. And that's because this is an early, typically a younger onset form of dementia. It's still less common under the age of 65 than Alzheimer's disease, but it is the second most common dementia under age 65. And the range is from the 5th to the 7th decade, so the 40s to the 60s. But there are patients that have presented in their 20s and 80s, and approximately 10% will present over the age of 70. So we shouldn't discount it in younger people and older people. If you ask of family history in patients who are affected by FTD, 40% will have some family history of either dementia or a psychiatric disease, but maybe not necessarily, specifically the disease that you're looking at or that they have. But there is some sort of a family history. But about 10% to maybe 20% have a true familial form of the disease that we call autosomal dominant inherited disease. And that means that there's a single gene involved. We all carry two genes or two copies of every gene, one from mom and one from dad. And if we have one copy of one of those genes that causes an autosomal dominant disease. That's all we need. And so we can pass that on to our children. And there's a 50-50 chance of passing on the bad gene. So if you look across generations of families, about 50% of each generation would have the disease, and that's a true familial form. Okay, so what about FTD and ALS? In FTD, there are primarily two major subtypes. The behavioral variant that we call FTD-BV, and this is the most common. And then there's another subtype that's called primary progressive aphasia, or PPA. And there are actually two types of PPAs, semantic and non-fluent. So these are language disorders, essentially, in which patients have difficulty using language. And I'm not going to go into the details because this is the one that's most commonly associated with ALS. So the overlap with ALS, again, up to 15% of patients with FTD will show signs of motor neuron disease, or ALS features. And as many as 50% of patients with ALS will display FTD-like features. Again, this can be very subtle or it can be very prominent. So many of them may be having very subtle features that go undetected. It's especially common to see in patients with bulbar forms of ALS, which means the form of ALS that affects our oral musculature and facial musculature. And then again, these, because we don't look as hard as we should, we may be missing a lot of these overlap cases. Some of the risk factors of FTD with ALS include older age, male, being male, lower education, family history of dementia, a low FVC, which is a forced vital capacity, a function of the lungs, and pseudobulbar palsy, which is a feature that can happen with brainstem disease and bulbar onset. So again, these are all features sometimes that are seen in bulbar ALS. The core features to make a diagnosis of FTD behavioral are three of the following features. And these are the frontal lobe features that I described earlier, is the disinhibition. So this is when you just, people just do things that really they shouldn't do. And I'm going to describe in a little more detail. Just kind of think about getting drunk and you have a lot of alcohol in your brain and you tend to be a little more disinhibited. Apathy can also happen. So almost the reverse, that just not sort of caring or having interest in things. A lack of empathy is an important feature that is seen in frontotemporal dementia. So people lose their empathy for others. Stereotype behaviors and compulsions. So an OCD type syndrome can develop in people with sort of checking the windows and doors and carrying out repetitive movements just because they make the patient more comfortable, but they don't accomplish anything. Hyperorality, so putting things specifically in the mouth, maybe is a more common thing in some people with frontotemporal dementia. And this also relates to eating, and people will tend to eat more. And they may have dietary changes where they have a more specific preference for certain foods, and they'll have to eat a certain food every day. And then executive dysfunction, which is again, your organizational and abilities and ability to strategize. So the key is that behavior is affected significantly more than memory in these patients compared to what we see in Alzheimer's type dementia, where memory is the major feature. So some of the difficult behaviors that we see, loss of personal and social awareness. So people become tactless, say things and do things that are inappropriate and often embarrassing to family members. Impulsiveness, inappropriate behaviors, off-color language. So, just being a little freer with foul language, talking loudly in church, or talking loudly in a movie, or, not listening to people to turn your phone light off, or, whatever it may be, things that someone should be able to control and their behavior and be aware of others. Those are problems that will occur. Disinhibition can be unrestrained sexuality, disrobing in public, violence. So just having difficulty controlling temper, having temper tantrums. So people will actually pound their fists on table, jump up and down on the floor if they don't get their way. And inappropriate joking. So joking and telling dirty jokes to your doctor and that kind of thing. And then judgment is a real problem. And this becomes a very difficult situation for a lot of families. And specifically with the lack of insight. So people don't recognize that they're having a problem with judgment or thinking. So they may perform some tasks that are threatening their health, their own health and the health of others. Driving dangerously, other dangerous activities. I've had patients climb bridges, try to get up to the top of bridge scaffolding. Gambling may be a new habit that patients develop. Stealing even. People will just pick up things from a store and walk out with them, not thinking about the implications of it. Resisting advice because they know better and they really don't have the insight. And so you can think of this syndrome as the inner voice that tells you what's appropriate and not fades away. So to evaluate frontotemporal dementia, we evaluate patients just as we would any other diagnosis or any other dementia. So one of the interesting aspects of this is because it is a behavior disorder, the diagnosis may be delayed for several years in people, that it's just sort of written off as maybe a mood disorder, or somebody's getting grumpy as they get older, or depression because they develop apathy. So sometimes it takes a long time for this to be recognized, and sometimes it's never recognized. The history of the presentation is key. So when I ask family members and spouses in particular about, why they're here, well, sometimes they can't put a finger on it, but there's a change in the character or behavior, that their spouse is not himself or herself anymore. They're a different person, but maybe can't describe it. They may have developed new habits, a rigid thought process, and so the arguments ensue between spouses that there's only this way to do something, and it's a very rigid thought process, even if it doesn't make sense, that's the only way to do something. Infidelity happens a lot with these patients, maybe early on in the disease process. And again, as I mentioned, gambling, alcoholism, new dietary habits, excessive purchasing, and this has also become a problem with online purchasing, that patients may run bills into the tens of thousands of dollars just buying things. Okay, and I've talked about these others. So we typically will focus then on the frontal lobe functions, as I mentioned, and the cognitive evaluation. So patients have a physical exam, and the cognitive evaluation will be a screening evaluation in the office, and we typically use this called the Montreal Cognitive Assessment because it does highlight some of the frontal lobe functions. But some patients will go on to a full neuropsychological battery, and which takes several hours, to complete, but it gives us a very detailed analysis of the cognitive function and which areas of the brain are most impacted by the disease process. Just to give you a quick idea, here you have to draw a clock, you put in the numbers, and then set the hands to the appropriate time. And so that's a planning process. That's an executive function that someone may have trouble with. This is a task requiring sort of multitasking, keeping two sets of information in your head. So the alphabet and then the numbering system. So you have to go up in numbers and through the alphabet and alternating between the two. So 1A, 2B, 3C, 4D, 5E. And that can be a challenging task for people with frontal lobe disorders. So then you can see that there's attentional tasks here that patients have to carry out, some abstractions, being able to understand similarities and other features of this. Tests are helpful, but this is the list of things that we would look at, focusing primarily on the frontal lobes. So blood tests are done. Of course, we rule out, other reversible causes of dementia, and then look at send the patient for neuroimaging. And so some of the things that are helpful in neuroimaging, here you see an MRI. This is the front part of the brain in the back, a side view. And you can see that from the beginning of the frontal lobe, which starts here, there's a significant amount of atrophy. This is all space. So the brain has shrunken considerably in this part of the brain compared to that. Now, 90% of the time, we don't get a nice, clear picture like this. It's more subtle, especially at the beginning stages of disease. So we usually will have to engage an imaging study that looks at activity of the brain. And this I had mentioned earlier, looking at brain activity. This is something called a PET scan, or positron emission tomography. And it's looking at, G stands for glucose, and it's a radioactive form of sugar. And the patient is injected with the sugar into a vein, and then we wait a little while the sugar gets to all areas of the body and the brain. And the areas of the brain that are working well will take up the sugar because they require a lot of energy to function, the neurons, brain cells. And the areas of the brain that aren't working well will shunt the sugar away. They don't need it, and they won't take it up because they're either the neuron cells are dying or dead already. And so you can see here that the brightness means lots of activity. So in this FTD patient, you see lots of activity in the back, but very little to no activity in the front parts of the brain. Now, this just shows you the difference between frontotemporal dementia and Alzheimer's. This is now looking at areas of decreased activity highlighted in red in frontotemporal dementia. So this is the frontal lobes and the temporal lobe. And then this is Alzheimer's disease, showing the back, the temporal lobe, and then the parietal lobe. So quite a different picture that we would see on these activity scans between these two diseases. And that's why it's very helpful for us in making a diagnosis of one or the other. Okay, so I'm going to try to, I don't want to steal too much time away. So I should, Tessa, be ready. I should be done in about 5 minutes. I'll try to get done in time for you. Okay, so what other special testing do we do? So genetic testing can be done. And genetic testing is done for a couple of reasons. If there's a strong family history, of course, we'd want to do genetic testing. But as I mentioned, there's only 10 to 20% of these cases are familial. But in general, it's a helpful test because there may be many more patients that don't have this autosomal dominant genetic form of these diseases that also have defects in some of these genes that are associated with also ALS and frontotemporal dementia. And I just want to highlight here the most common of the genes associated with this disease combination is C9 open reading frame 72. And I'm not going to steal the thunder of Dr. Roos. He's going to talk specifically about this. So I'll leave that for him for the sake of time also. But you can see that there's overlap of that specifically with ALS and FTD. Some of these genes that I've highlighted here can produce either FTD or ALS or both. And then some of these genes produce mainly or will cause mainly ALS. But we're still learning and adding to this genetic profile. Now there's some genetic testing that can be done for a nominal fee, and I consider nominal $250, and this entire panel can be done clinically if insurance doesn't pay for it. In the past, we've had to pay $5,000 to $10,000 to get that done, so I consider it a bargain now. And then finally, extra testing might be spinal fluid assessment. The diagnostic testing from spinal fluid is not there for frontotemporal dementia yet. It is, though, for Alzheimer's. So we can look at spinal fluid from a lumbar puncture and measure proteins that are involved in Alzheimer's disease and do quite well, 85 to 90% specific and sensitive for Alzheimer's disease. So if we're concerned about whether this is frontotemporal dementia versus Alzheimer's disease, the spinal fluid test can help that. Okay, so what do we do to manage? Now that we've made a diagnosis one way or another, how do we manage this disease? There's really no current treatments for FTD or FTD with ALS. The primary management of disease is behavioral management because, again, behavior is a primary feature that we see in these diseases. The behaviors can be very problematic, and so they really need to be addressed. Now, we try to avoid pharmacologic means, but in some cases, some of these are treated with some pharmacologic agents. So a lot of the compulsive behaviors, the apathy, attention deficits, and some of the agitation, irritability, and anxiety may respond to certain antidepressants. And in particular, we use antidepressants that build up serotonin. And it's interesting that if you look at frontotemporal brains of patients, from patients with frontotemporal dementia, there is a significant reduction of serotonin in the brains, in the networks in those patients. And so this builds up the serotonin and may have a fairly broad effect on many of these behaviors. In some cases, psychoses develop, which is really hallucinations or delusions. So, seeing things or hearing things, or thinking that something is true that really isn't, that your spouse is having an affair with someone, or, there are people that are in the house or doing things, manipulating things in the house on you, or there are people from space coming down to take over. So those, when they're serious and affecting the patient's well-being, they really do need to be treated. And so we start out with very low doses of antipsychotic agents because those are serious medicines, and patients can have significant side effects associated with them. So we do our best to manage the behaviors and educate the families primarily and guide them through their disease. And that's done best by our social worker, and the social workers really have a tremendous burden and play a significant role in managing this disease. So I'm going to now hand it over to Jumana to introduce Tessa, our expert social worker at the Memory Center, who helps with these patients.
Thank you, Dr. Mastrianni. This was amazing. Thank you so much. Great information.